We call for the next speaker, Dr. Mohamed Abdel من قناة السويس. He will talk about the quartet study. Dr. Abdel.
شافي لو سبت لنا دقيقة يبقى كتر خير.
Most likely more إن شاء الله.
15.
إن شاء الله. Dear chairpersons and my dear professors and colleagues, I'm very proud and delighted to be amongst you today, represented Science Canon University in providing this insight about this very interesting presentation or study, which is the Quartet Trial. Its whole title is the initial treatment with a single pill containing a quadruple combination of quarter dose of blood pressure medicines versus standard dose monotherapy in patients with hypertension, which is called the Quartet Trial, which was a phase 3 randomized double-blind active control trial. It's a recent trial published in August in the Lancet and introduces a whole new concept in which we tackle newly diagnosed patients with hypertension, either treatment naive or only receiving monotherapy as the enlisted patient population in this trial. The rationale behind it was that most patients eventually with hypertension will need multiple medication to control their blood pressure, despite our best effort to control blood pressure with a single or monotherapy. But barriers to expand this approach stand as follows. Treatment inertia, especially in patients newly diagnosed with mild to moderate hypertension. Physicians tend to delay the up-titration of drugs for long times before achieving blood pressure control. Fears of the side effects of multiple medications, either on the physician side or the patient side. And despite contemporary guidelines, which is encouraging and actually recommending even in mild hypertension to start with a combination therapy, single pill dual combination therapy, still in registries in real life situation in Australia, for example, which is the place where this trial was done, even in Europe and United States, still monotherapy as a standing protocol for patients with newly diagnosed hypertension remains by far the most commonly used approach by most physicians. The quadruple quarter dose treatment for patient hypertension, does it have a history? Actually, this is the first randomized double-blinded trial to address this question, but it has a history, of course. It has been tested in open-label limited cohorts for a limited number of times, with no blinding whatsoever, in order as a proof of concept to see whether it works or not and whether it's safe or not. It definitely simplifies treatment regimens and thus will end up enhancing adherence. Probable better efficacy, of course, we are using multiple medications, actually tackling multiple pathophysiologic pathways, which will buffer treatment inertia. We will start the multiple treatments at the start. The physician will not have to up-titrate or add additional drug along the way while following the patients up. Possible better side effect profile due to ultra-low dose of its individual components. So fear of certain side effects of certain groups in certain population of patients might be mitigated by using the ultra-low dose of single components of this quadruple therapy. This was the rationale behind a possible beneficial approach using this quadruple therapy. It is to be reminded that this is like to test a fixed dose regimen in starting treatment and was not driven by eventual blood pressure targets. Of course, it was an endpoint whether which protocol will achieve either the standard lenient blood pressure control below 140/90 was a secondary endpoint to test which will reach the tight control below 130/80, but it was not target, and the patients or the up-titration later on while following up the patient was designed only to reach the lenient or the conventional blood pressure target. This was the study design and the inclusion criteria. Almost like every hypertension trial, it's the same adults above 18 years of age and the same exclusion criteria. But to be enlisted in the trial, the patient either had to be a treatment naive with clinic systolic blood pressure between 140/179, or diastolic blood pressure between 90 and 109 millimeter mercury, or average day ambulatory systolic blood pressure above 135 and diastolic 85. On the other hand, patients could be enlisted in the trial if they have already received drug, provided that this drug was only monotherapy, and on follow-up or at the time of randomization, their systolic blood pressure, despite receiving monotherapy, was clinic systolic blood pressure 130 until 169, or diastolic blood pressure 85 until 104, or by average day ambulatory blood pressure, systolic blood pressure above 125, diastolic above 80. The initial randomization was 650 patients, among which only 591 patients enlisted finally in the trial. LDQT, which is the low dose or ultra low dose quadruple therapy, 300 patients. The comparator active monotherapy arm, those were all receiving irbesartan 150 milligram. It was supposed that the components of the quadruple therapy is the quarter of the conventional dose or concentration of each drug. What was the pill or the capsule formed of? Irbesartan 37.5 milligram, amlodipine 1.25 milligram, indapamide 0.625 milligram, and bisoprolol 2.5 milligram. Actually, the major outcome or the primary outcome was tested at 12 weeks, or the final visit, in which all the population, the 591 patients, reached. And the primary outcome was the unattended office systolic blood pressure measurement. This was the primary outcome. Multiple secondary outcome in terms of efficacy and safety endpoints, like the diastolic unattended blood pressure. There was an extended follow-up as well at 12 months or 1 year to see whether the sustained, there was sustenance of the effect of the initial effect of this protocol has been maintained at 1 year or not. Also, testing systolic blood pressure, diastolic blood pressure, whether unattended or office blood pressure reading, but there was only a single primary endpoint, which is difference in systolic blood pressure, unattended systolic blood pressure reading in the office at 12 weeks. A visit at 6 weeks has been held in order to up-titrate therapy, and it was determined the first drug to up-titrate with was amlodipine 5 milligram, in case the clinic blood pressure was still above 140/90 at 6 weeks. Finally, the extended group, which was 206 patients in the quadruple therapy group and 211 patients in the monotherapy group, which reached 52 weeks, they were also evaluated again for the extended follow-up and the extended sustained effect of the drug. And this was the components of the two drugs in the randomized group. And the primary endpoint, it ended up that the quadruple or the quad pill, the blood pressure, unattended systolic blood pressure, was around 120 millimeter mercury at 12 weeks, as compared to monotherapy 127 millimeter mercury, a difference of 7 millimeter mercury, which was deemed very highly significant in terms of difference. And as a part of also a secondary endpoint, diastolic blood pressure was similarly reduced by around 5.8 millimeter mercury at 12 weeks. Seeing the natural history of response along the extended group as well as 52 weeks or 12 months, the effect was still sustained by a difference of an unattended systolic blood pressure reading of 7.7 millimeter mercury, lower in the initial quad pill receiving group. This is the percentage of those reaching blood pressure control or successfully reaching blood pressure control as measured by office blood pressure, whether its blood pressure target achieved the conventional target below 140/90 or the tight blood pressure below 120/80, whether it was 6 weeks, 12 weeks, 26 weeks, or 52 weeks. And in all the parameters, in all the assessment, whether we are talking about conventional or tight blood pressure control, it was also in favor of the quad pill receiving group as opposed to the monotherapy receiving group. This is in terms of the need in each group of up titration or at adding further drug at each point of time, which was 12 weeks and 52 weeks. We can see that 83.5% of those in the intervention quadruple group did not need any up titration at 12 weeks of follow-up, and almost 80% did not need this up titration as well at 52 weeks, as opposed that almost half of the patient needed such an up titration with either single pill monotherapy amlodipine or additional drug at the discretion of the treating physician according to the study protocol. In terms of serious or adverse side effects, there was a tendency towards dizziness, of course, in the intervention quad pill group, which was expectedly so because of the potency of the pill, as opposed to monotherapy. Otherwise, in terms of adverse effect, it was relatively or greatly safe as opposed to monotherapy. In conclusion, a strategy with early treatment of fixed dose, quadruple, quadruple dose combination achieved and maintained greater blood pressure lowering compared with the common strategy of starting monotherapy. This trial demonstrated the efficacy, tolerability, and simplicity of a quad pill based strategy. In discussion, I only have to say that being attentive of the fact that most patients will need combination therapy is already a part of our practice, a part of our guidelines. Upfront combination therapy with 2 agents and using third and a fourth agent according to follow-up is actually the standard of care. So we are gaining the acceptance of using upfront combination therapy in hypertension. Also, we can expect that such a strategy might gain like acceptance in the future because of the versatility and the multiple pathophysiologic pathways inflicting hypertension or incorporated in the pathophysiology of hypertension. And in theory, hitting multiple targets or all targets at the same time from the very start might prove beneficial in a lot of patients. Of course, the relative weight of each pathophysiologic pathway is different from patient to patient, and we only cluster patients according to age or gender or comorbidities to foresee which is the major contributing pathophysiologic pathway, but we don't have actually very accurate tools to discriminate which is more contributor. So hitting hard and hitting at each and every single cylinder from the very start might prove beneficial on the long run in terms of control and maintaining that control. Actually, this approach is not only in hypertension. Since 2015, Defronzo already introduced and has been in the field of diabetes, has been mastering and evolving the upfront combination, even triple therapy in those with newly diagnosed type 2 diabetes, like this study, the EDICT study. In the cardiovascular field, already there have been proof. Dr. Karim might tell us as well that triple up front combination therapy might be beneficial in intermediate risk patients, also in terms of enhancing outcome and lifestyle and 6-minute walk test in patients with pulmonary hypertension. With this, I finally conclude my discussion and the strengths and limitations of the study. That it was large, multi-site randomized trial, double-blind design, comparison with current guideline-based blood pressure management, objective measurement of the primary outcome and embedded economic and acceptability evaluation at the level of the local, of course, policy and procedures in Australia. The limitation that it was a single country study, the trial not powered for cardiovascular events, ultra low dose of outcome, although might prove effective or safe in terms of adverse events, also might, the patient might not gain the full benefit of certain groups in which the outcome in hypertension is gained from, like not achieving large dose from amlodipine, not reaching high dose of ARBs or AC inhibitors. This actually the patient might be hindered to obtain the full potential of the pleiotropic effects of such agents. The future direction based on this is to compare this to current standard of care. Actually, the standard of care that is evolving is actually a combination strategy, is not monotherapy. It's dual pill combination. Maybe if we compare such a strategy with just a dual single pill combination, it will not be proved that beneficial or no overwhelming benefits as expected. And further on, if this proves beneficial in terms of blood pressure control and outcome, cardiovascular study, of course, is going to be oriented. And thank you very much.
شكرا دكتور محمد على الابلكيشن انك انت وفرت لنا دقيقه ونص، وانا طبعا عندي ديسكشن كتير مع الدكتور محمد بس هقولها له بيني وبينه، لان انا هنفذ اللي قطعناه على نفسنا، وهناخد سؤال او على الاكثر سؤالين من الفلور لو اي حد ليه سؤال. طيب ما فيش حد ليه سؤال، من ضمن الديفيكولتيز في الحكايه دي زي ما انت قلت ان بعض يعني there is personal variability لكل واحد، انت بتختار له الدواء، انت بتختار بيتا بلوكر لواحد انت وكذا وكذا وكذا، فدي يعني هتحرمك من انك انت تاخد الدوز اللي هي منصوص عليها انها كان give the effect for a certain person. الحاجه الثانيه الديفيكولتي في المانيفاكتشر، انا عايز بقى انا معايا 4 ادويه وعايز ازود هنا ربع وزود هنا نص وازود هنا تلت، يعني this will be a heroic task for the company doing the variable standards of the medication including in the يعني احنا كنا بنقول ولنا كلام يمكن هنتكلمه في ال questions and answers with the extra لما نبتدي بcombination therapy من الاساس، هل هذا صحيح او مش صحيح؟ لانك انت تبتدي بcombination او تبتدي بمونوثيرابي دي لها indication مش بمزاجنا، it depends على ال age of the patient, it depends على ال level of the blood pressure, it depends على ال risk of the patients، فكل حاجه لها اختياراتها ولها، فانا مش عارف ان انا اخد 4 ادويه مره واحده على جرعات صغيره قوي، مع ان كل الجايد لاينز بتقول لنا انك to achieve the effect you need you have to have a certain dose for a certain drug.
Yes, and I actually mentioned this limitation in this approach. والقصه المانيفاكتشرنج دي is going to be prove a problem، لان حتى واحنا بنبدا الالترا لو دوزز ديت، طب انا عايز ان عيان اوريدي دخل بهايبوتنشن في القصه ديت، هل ان انا هصنع له الترا لو دوزز ولا لا؟ القصه هتبقى هندرنج شويه. It's a proof of concept. Returning back للفيرست question، هو طبعا any group of patients with special requirements and compelling indication of a certain agent will also hinder the use of this strategy, or it's going to be added on it. The other thing, الميديسن اللي moving towards one size fits all دوت غالبا eventually will not work because the future is for individualized medicine. And actually, at a certain point, we might return back to monotherapy because the demographic and the genetic background of a certain patient will tell us that he's going to be controlled on irbesartan 175 milligram. This is where medicine is going. So any trial to set us back with a one-size-fits-all approach is going to be very limited and appropriate for a very limited group of patients. Thank you very much.